Leadership Lessons from Pandemic Reconfiguration. My name's Sophie Gatfield. I'm a Trauma and Orthopaedic Registrar in Severn Deanery, out of programme as a National Medical Director's Clinical Fellow. In March of 2020, the British Orthopaedic Association Standards for Trauma published guidance for the management of patients with urgent orthopaedic conditions and trauma during the coronavirus pandemic. They advised that patients should have definitive decision-making at first attendance, and units should deliver a trauma clinic for all patients who attend the emergency department with minor injuries. This was clearly a significant deviation from business as usual for orthopaedic departments across the country. Literature review identified multiple single-centre descriptions of the reconfiguration, but no multi-centre analysis could be identified. We did identify an emergency medicine phenomenological study and aimed to perform a similar study to explore the experiences of different orthopaedic clinical leaders and identify consistent themes that could assist with continuous improvement of minor injury care. The study was devised in November 2020. This was just before England's second national lockdown. This was a phenomenological approach, and we used Purposeful sampling using the British Orthopaedic Director Society network. We performed 9 semi-structured interviews with clinical leads across England and then performed thematic analysis of the summarised transcripts. Thematic redundancy was achieved by interview 5, but we continued in order to get an apt geographic spread across the UK. Limitations of this methodology, of course, this was a convenient sample for participants to be available during the 2-week study period, and voluntary participation may have been more likely to demonstrate successful change than unsuccessful. A single interviewer may have introduced bias, but we did use 3 authors to perform thematic analysis. Of the 9 sites involved, 4 used an orthopaedic space that was redundant in order to run the minor injuries units, such as an outpatient clinic or day case surgery. 1 used an entire elective hospital. 2 allocated trauma and orthopaedic consultants to the emergency department during daylight hours, and 2 allocated an additional consultant to clinic to review minor injury cases. 6 key themes were identified. It's rewarding to provide a quality of service. Multi-professional cross-pollination occurs with collaborative working. Service reconfiguration was easy to start but difficult to stop. The benefit to patients of early senior decision-making was unanimous, and a good relationship with ED yielded smoother transitions. Most significantly, the crisis was a catalyst for change, and some service improvement innovations that had been blocked by bureaucracy for many years were able to be introduced in a very short space of time. Reduced barriers to change is reflected across the healthcare economy, and NHS Confederation and NHS Providers Research White Paper, the end of 2020, showed that reduced bureaucracy and strong innovation were 2 of the most significant benefits to the health service of this pandemic. Overall, the authors feel there are 3 key lessons to take away from this pandemic. Utilise the momentum of a crisis response to overcome change barriers. Start planning reconfiguration step down early, and cross-specialty collaboration and communication is key. Thank you very much for listening, and I welcome any questions.